talk about the 2025 focused update of the 2019 ESC guidelines for management of dyslipidemia. Will be our agenda, and we will start with the assessment of the total cardiovascular risk. Actually, the most famous risk stratification systems are SCORE2 and SCORE2-OB. SCORE stands for Systematic Coronary Risk Evaluation. SCORE2 system estimates the 10-year risk of the fatal and the non-fatal cardiovascular events in apparently healthy individuals aged between 40 and 69 years, while SCORE2-OB, OB stands for older persons, estimates the 10-year risk of fatal and non-fatal cardiovascular events in apparently healthy individuals aged between 70 and up to 89 years. This risk is estimated based on the age, gender, smoking habits, total cholesterol level, HDL cholesterol level, and systolic blood pressure. And actually, total cholesterol and HDL cholesterol levels are used here to calculate the non-HDL cholesterol level, which is considered an important input in the calculation of SCORE2. But you should be aware that SCORE2 and SCORE2-OB are not used in the following patients. Number one, patients with established atherosclerotic cardiovascular disease, such as patients with previous stroke, peripheral arterial disease, and coronary artery disease. Actually, these patients are already at very high risk for cardiovascular events. Number two, patients with chronic kidney disease. Patients with chronic kidney disease are classified into high or very high risk category according to the GFR level. Number three, patients with diabetes. In diabetes, we use SCORE2 diabetes. Number four, patients with familial hypercholesterolemia. Already, they are at high or very high risk. And finally, LDL cholesterol level more than 190 milligram per deciliter, which is considered a markedly elevated single cardiovascular risk factor, and it is already high risk by default. So what is the difference between the old SCORE system and the new SCORE2 or SCORE2B systems? This is a very nice comparison between both. SCORE, it was designed to estimate the 10-year risk of fatal cardiovascular events, while SCORE2 and SCORE2-OB are designed to estimate the 10-year risk of both fatal and non-fatal cardiovascular events. SCORE is used to assess the risk in apparently healthy individuals aged between 40 and 69 years, while SCORE2 and SCORE2-OB are used to assess the risk in apparently healthy individuals aged between 40 and up to 89 years. SCORE2 assess the risk in patients from 40 to 69, and SCORE2-B assess the risk in patients from 70 and up to 89 years. And even the input that you enter in the calculation are different. SCORE system, you should have a data on the age, gender, smoking habits, total cholesterol level, and systolic blood pressure, while in SCORE2 and SCORE2-OB, the risk is estimated based on the age, gender, smoking habits, and the non-HDL cholesterol level, and finally systolic blood pressure. What are the reasons behind this change from SCORE to SCORE2 or SCORE2-OB? Actually, many randomized trials have demonstrated that lowering the LDL cholesterol level reduces the risk of both fatal and non-fatal myocardial infarction and ischemic strokes, as well as ischemic events in peripheral arterial disease. So, because the cardiovascular disease morbidity, which include non-fatal MI and non-fatal stroke, combined with the cardiovascular mortality, it will better reflect the total burden of atherosclerotic cardiovascular disease. And this is the reason behind changing the risk assessment tool from SCORE to SCORE2 and score 2 OB. As a general concept, it is estimated that the risk of total cardiovascular events is 2 to 3 times higher than the risk of the fatal cardiovascular events. So, in this focused update, a 2 multiplier was used to convert the previous score 2 based threshold into score 2 or score 2 OB based threshold, as we will demonstrate in the next slides. This is a very nice comparison between the old score system and the newer one, score 2 and score 2 OB, and the score 2 diabetes, which is used in diabetic patients. Actually, patients are classified in 4 different risk categories, and we have a different cutoff values for each risk category and in each score. In the old score system, the numbers was less than 1% is classified as low risk, from 1 to less than 5% moderate risk, from 5 to less than 10% high risk, and the very high risk was defined as score 10% or more. If we multiply this value by 2, we will get the score 2 values. So score 2 or score 2 OB less than 2% is classified as low risk, from 2 to less than 10% is moderate risk, from 10 to less than 20 is high risk, and 20 or more is classified as a very high risk. While in score 2 diabetes, less than 5% is classified as low risk, from 5 to less than 10% is moderate risk, from 10 to less than 20 is high risk, 20% or more is very high risk. So, for patients with type 2 diabetes without atherosclerotic cardiovascular disease, the guidelines recommend the use of score 2 diabetes to estimate the 10-year risk. It should be noted that score 2 and score 2 OB estimating algorithms were derived from cohorts of participants without clinical atherosclerotic cardiovascular disease who were not receiving lipid-lowering therapy. As a result, these algorithms shouldn't be used to estimate the risk among persons with existing atherosclerotic cardiovascular disease or among persons currently on the lipid-lowering therapy. And they shouldn't be used to reassess the risk using the lipid measurements obtained after initiating the guideline recommended lipid lowering therapy. So this is an important limitation here. These are the updated cardiovascular risk categories. Actually, no significant change from the old guidelines apart from the cutoff value for score 2 and score 2 OB, as we have demonstrated in the previous slides. And the definition of significant plaque in patients with atherosclerotic cardiovascular disease was clearly defined as stenosis more than 50%. It wasn't clear in the old guidelines. Calcium score value was added more than 300. And the target organ damage in patients with diabetes is defined as microalbuminuria, retinopathy, or nephropathy. Otherwise, no change from the previous guidelines. And the same apply to the other risk categories. Just the cutoff value of score 2 and score 2 OB were added to define the other risk categories. But now we have a new risk category which is called extreme risk. This is higher than the very high risk category. Patients with atherosclerotic cardiovascular disease who experience recurrent vascular events while taking a maximally tolerated statin-based therapy, or patients with polyvascular disease, coronary and peripheral arterial disease. These patients are classified as an extreme risk category, and the target LDL in this category is lower than 40 milligram per deciliter. And one of the new updates in these guidelines is the addition of the risk modifiers. These risk modifiers can be used in patients with moderate risk for further reclassification. For example, if we have a patient with moderate risk on these risk scores that we have mentioned in the previous slide, but he has also evidence of risk modifiers, then the risk will be upgraded from moderate risk to high risk. And the summary of these slides was clearly mentioned in the recommendations of the guidelines. We will pass this slide to save time. The second important update was the non-statin therapy. Let's start with bempedoic acid. Bempedoic acid is an oral prodrug that reduces the LDL cholesterol by inhibiting the ATP citrate lyase, an enzyme upstream of the statin pathway. And because its activating enzyme is absent in skeletal muscle, it has a low risk of muscle-related side effects. This is the main value of the bempedoic acid, and it is the clear advantage of bempedoic acid over statin is lack of muscle side effects. Bempedoic acid single dose available 180 milligram daily lowers the LDL cholesterol by about 23% alone, and 18% with statins and up to 38% in combination with ezetimibe. This drug also decreases the CRP level without raising the blood sugar in non-diabetics or pre-diabetic patients, and the clear outcome trial demonstrated its potential for reducing the cardiovascular events in statin intolerant high-risk patients. It can result in a small reversible increase in the uric acid, which means that we need caution in patients with gout, although this is not considered an absolute contraindication for its use. The second one is inclisiran. Inclisiran is a small interfering RNA therapy that reduces the LDL cholesterol level by inhibition of the PCSK9 synthesis, which offer a novel alternative to the famous PCSK9 monoclonal antibodies such as alirocumab and evolocumab. Phase 3 trials have shown that it can lower the LDL cholesterol level by about 50%. And now we have large ongoing cardiovascular outcome trials involving more than 33,000 patients with cardiovascular disease and are expected to provide more definitive evidence of its impact on cardiovascular events, and the results are anticipated in 2026 and 2027. The third one is evinacumab. Evinacumab is a monoclonal antibody used in patients with homozygous familial hypercholesterolemia, in whom statins and the PCSK9 inhibitors have little efficacy and may not be sufficient to adequately reduce the LDL cholesterol level. And it can reduce the LDL cholesterol level by about 50%, so it is a very effective drug. As a general concept, these task force guidelines recommend to add non-statin therapies with proven cardiovascular benefits, such as ezetimibe, PCSK9 monoclonal antibodies, or bempedoic acid, taken alone or in combination to lower the LDL cholesterol if the LDL cholesterol goals are not achieved with the maximally tolerated statin dose. And the choice between these options is based on the magnitude of the additional LDL lowering and patient preference and treatment availability, as well as cost. The third important update is the use of lipid-lowering therapy in patients with acute coronary syndrome. After an acute coronary syndrome event, it can take up to 12 weeks to initiate the optimal LDL cholesterol lowering treatment under the current guidelines, despite this early period being critical and high risk. Observational data revealed that intensive lipid lowering therapy is often underprescribed and poorly adjusted after hospital discharge, leaving many patients without achieving the LDL goal. Contributing factors include physician prescription inertia, patient non-adherence due to its side effects or statin hesitancy, and the gap in the post-discharge follow-up. And these highlight an important need to improve early and intensive lipid management post-acute coronary syndrome. Recent data from a Sweetheart registry reported that the lowest risk of cardiovascular events in those patients who achieved the early and sustained LDL cholesterol lowering to the recommended goals after MI. A stepwise approach for LDL lowering after MI might therefore result in delayed goal achievement as compared with the early intensification of the treatment. So, in summary, this data support a new concept: the sooner, the lower, the better, as a therapeutic strategy for LDL lowering in patients with acute coronary syndrome. So, in this focused update, intensive LDL cholesterol lowering to be considered in all patients with acute coronary syndrome with immediate initiation of statin therapy with a combination treatment with one or more of the classes of the non-statin therapy with proven cardiovascular benefits, such as ezetimibe, PCSK9 monoclonal antibodies, or bempedoic acid, depending on each patient lipid lowering therapy prior to the prior to the acute coronary syndrome events. Several drugs and the drug combination and the various efficacies and the onset of action are available to enable such a strike early and strong approach. So this is a new concept in patients with acute coronary syndrome to start with combination therapy from day one. Beyond the treatment in acute coronary syndrome phase, LDL should be rechecked after about 4 to 6 weeks after initiation or after intensification of the lipid lowering therapy. And this was given a class 2A recommendation in the guidelines, initiating a combination therapy with high intensity statin plus ezetimibe during index hospitalization for acute coronary syndrome should be considered in patients who were treatment naive and are not expected to achieve the LDL goal with statin therapy alone. We have also a new recommendation on the little protein A or lipoprotein A. Little protein A should be considered at least once in every adult lifetime, either at the first lipid profile or at the next one if the lipid profile have previously been performed. Screening is particularly relevant in younger patients with familial hypercholesterolemia or premature atherosclerotic cardiovascular disease without a clear explanation. No evidence of the classic cardiovascular risk factors, or in patients with family history of premature atherosclerotic cardiovascular disease. Actually, the little protein A or lipoprotein A level may increase after menopause, and a second measurement is reasonable, particularly if the premenopausal levels were borderline. Whether lowering the little protein A reduces the risk of cardiovascular disease and aortic valve stenosis progression has yet to be shown. We don't have a clear evidence on this till now. In the absence of a specific lipoprotein A lowering therapies, early risk factor management and more intensive LDL cholesterol lowering is reasonable, considering both absolute absolute cardiovascular risk as well as the baseline lipoprotein A level. So this is very important point. Till now we don't have a specific therapy to lower the little protein A. Although a small studies have suggested that statins may have a slight lipoprotein A increasing effect, individual level data on participants in 7 randomized trials found that statins had no effect on the lipoprotein A concentration. This is very important. The previous guidelines mentioned that statins may increase the level of lipoprotein A, but in this newer update, it is clearly stated that statin has no effect on the level of lipoprotein A. So the clinical decision making should be directed mainly by the degree of elevation of the lipoprotein A and the patient other risk factors, and patients with high level of lipoprotein A strongly encouraged to take or to continue to take high intensity statin if their risk is sufficiently high. And for the recommendations, we have a clear recommendation regarding the measurement of lipoprotein A. Lipoprotein A above 50 milligram should be considered in all adults as a cardiovascular risk enhancing factor, with a higher levels associated with greater increase in the risk. What about people with HIV? This is also from the new updates in these guidelines. Statin therapy is recommended for people in primary prevention, aged 40 years or more, with HIV, irrespective of the estimated cardiovascular risk and the LDL cholesterol level, to reduce the risk of cardiovascular events. Also, oncology patients. Statins should be considered in adult patients at high or very high risk of developing chemotherapy-related cardiovascular toxicity to reduce the risk of anthracycline-based cardiac dysfunction. So we will not adopt the classic strategy in patients with cancer or on patients with HIV. We will not calculate the SCORE2 and the SCORE2B, as these patients are actually at increased risk by default. Clear recommendation against the dietary supplements, the famous omega-3 capsules, dietary supplements or vitamins without documented safety and significant LDL lowering efficacy are not recommended to lower the risk of atherosclerotic cardiovascular events. What about hypertriglyceridemia? As we all know, triglyceride levels are associated with cardiovascular risk independent of the LDL levels. With respect to the pharmacological treatment of hypertriglyceridemia, these guidelines continue to recommend statins as a first drug of choice to reduce the cardiovascular risk in high-risk patients. Overall, in contrast to the opposite evidence of atherosclerotic cardiovascular disease risk reduction with LDL lowering therapies, the efficacy of triglyceride lowering with fibrates in reducing the cardiovascular risk has not been established. These guidelines support a Class 2B recommendation of the 2019 ESC guidelines for the use of fenofibrate or bezafibrate, and fibrates for sure are not indicated to lower the serum cholesterol or LDL levels. It is used to lower the triglyceride level. But the strongest recommendation for management of hypertriglyceridemia actually was given for the famous Ecosa pentacell based on the Reduce It trial. So this is the recommended second line after statin for management of hypertriglyceridemia. So in patients with elevated fasting triglyceride level between 135 and up to 499, and despite of statin therapy, it is recommended to add on icosapentasyl 2 gram twice daily. Was written here in the recommendation. High dose icosapentasyl 2 gram twice daily should be considered in combination with statin in the high risk or very high risk patients with elevated triglyceride level to reduce the risk of cardiovascular event. We have also a new drug called volenzosin. It is given 300 milligram once weekly, and should be considered in patients with severe hypertriglyceridemia, triglyceride more than 750 milligram, due to familial chylomicronemia syndrome, to lower the triglyceride level and to reduce the risk of acute pancreatitis. Let's remind you with the LDL target and the non-HDL target in the different risk categories. Actually, this hasn't been changed from the old guidelines, but in order to provide a complete overview of the dyslipidemia management, we should be aware of our targets. The primary target in management of dyslipidemia is the LDL cholesterol level, while the secondary target is the non-HDL cholesterol level. So after achieving the primary target, which is the LDL cholesterol level, try to achieve the secondary target, which is non-HDL level. The target LDL in low risk category is less than 116 milligram per deciliter, moderate risk less than 100, high risk 50% reduction from the baseline, then achieve an absolute value below 70, very high risk 50% reduction from the baseline, then achieving an absolute target less than 55, and the new category extreme risk, the target LDL is below 40 milligram. Simply to calculate the non-HDL cholesterol, just add 30 to the LDL cholesterol target. So the target non-HDL in moderate risk category is less than 130. The target non-HDL in high risk is below 100, and the target non-HDL in the very high risk is below 85 milligram. And this was a very nice summary demonstrating the different risk categories and the target and the corresponding LDL target. This slide is also very important and actually very, very confusing. I intended to show it to provide some explanation on this relatively complex slide. Actually, I will focus on the red boxes. The red boxes here refer to the drug therapy, the indications of drug therapy from the start, without the need to wait for the lifestyle modification first. In patients with high risk, with patients with high cardiovascular risk, if the LDL cholesterol level is 100 and up to 116, lifestyle modification and concomitant drug intervention. So the value of LDL at which we should start the lipid lowering therapy in patients with high risk is 100 milligram. What about patients with very high risk but for primary prevention? The LDL cholesterol value that necessitates initiation of drug therapy together with the lifestyle modification is LDL cholesterol level 70 milligram or more. Finally, patients with very high risk category but secondary prevention, all these patients, regardless the LDL cholesterol level, should receive lipid lowering therapy, mainly statins, to lower the cardiovascular risk and to benefit from the non-lipid lowering effect of statin or pleiotropic effects of statins. Just to remind you, with the moderate intensity and the high intensity statin is a daily dose that can lower the LDL level by approximately 50%. such as atorvastatin 40 to 80 milligram, rosuvastatin from 20 to 40 milligram, while moderate intensity statin is the statin dose that can lower the LDL by approximately 30 to up to 49%, such as atorvastatin 10 to 20, rosuvastatin 5 to 10, simvastatin 20 to 40 milligram. So let's see the stepwise approach to achieve the LDL cholesterol target. Actually, this is not written in the guidelines. I have created this approach based on the guideline recommendation to simplify the management. Step 1, we start with the maximally tolerated statin dose. And in patients with statin intolerance, you can give bempedoic acid. And also you can use ezetimibe. Step 2, if the LDL target is not achieved in step 1, you can use the dual combination, either maximally tolerated statin dose plus ezetimibe or maximally tolerated statin dose plus bempedoic acid. In patients with statin intolerance, we have to use bempedoic acid and ezetimibe. If the LDL cholesterol level target is not achieved in step 2, we will use triple combination. Basically, maximally tolerated statin dose with either ezetimibe and bempedoic acid, or ezetimibe and the PCSK9 monoclonal antibody, or bempedoic acid and the PCSK9 monoclonal antibody. And the choice between these options depend on the baseline LDL cholesterol level, risk category, target LDL level, and we will show the comparative efficacy of the different combination in the next slide. In patients with statin intolerance, you will use PCSK9 monoclonal antibody plus ezetimibe plus bempedoic acid. And the final step will be the use of quadruple combination. If the LDL target is not achieved on the triple combination, we will use maximally tolerated statin dose plus ezetimibe plus bempedoic acid plus PCSK9 monoclonal antibody. It should be noted that in many patients who don't achieve the LDL target on statin, ezetimibe, and bempedoic acid, adding a PCSK9 inhibitor to a statin and ezetimibe, or to statin and bempedoic acid, is usually sufficient to reach the LDL target without the need to use the quadruple therapy. This is the comparative efficacy of the different combination, starting with the ezetimibe that can cause reduction in the baseline LDL by about 20%, and ending with the quadruple combination, PCSK9 monoclonal antibody plus high intensity statin plus ezetimibe plus bempedoic acid, which can result in 86% reduction from the baseline LDL level. Important tips: PCSK9 monoclonal antibodies are approved only for very high risk patients. Inclisiran is considered a novel alternative to the PCSK9 monoclonal antibodies. And let's remind you with the doses. Ezetimibe is 10 milligram orally once daily. Bempedoic acid 180 milligram orally once daily. Parenteral agents, alirocumab 75 milligram subcutaneous every 2 weeks. If the LDL response is inadequate, you may adjust the dose by giving 150 milligram subcutaneous every 2 weeks. Volocumab 140 milligram subcutaneous every 2 weeks. Inclisiran 284 milligram administered as a single subcutaneous injection initially, then a second dose after 3 months, then the maintenance dose every 6 months after that. This is 2 practical slides. Then we will finish our presentation. This is a suggested approach for a patient with abnormal lipid profile with indication for drug therapy. Before starting the treatment, you should repeat the lipid profile to confirm the LDL values, and you have to obtain at least 2 measurements, interval from 1 to 12 weeks. except in patients with acute coronary syndrome or very high risk patients, we should start the treatment immediately. Check baseline liver enzymes and total CK, exclude secondary causes such as hypothyroidism and drug cause of dyslipidemia, and don't forget to screen the first degree relatives in patients with familial hypercholesterolemia, and we suspect familial hypercholesterolemia if we have an LDL cholesterol level 100 milligram or more. And finally, this is a very common clinical scenario: what to do with an accidentally discovered markedly elevated LDL cholesterol level in a healthy individual. Let's adopt this stepwise approach. We will repeat the lipid profile after at least 1 week to confirm. We will rule out the secondary causes, as we have mentioned, the hypothyroidism or drug causes. Don't forget to screen the first degree relatives, get a baseline labs, liver enzymes, and the total CK. No need to calculate any risk score. LDL 180 milligram alone is classified as a high risk patient. It is markedly elevated single cardiovascular risk factor. If no contraindication, start with high intensity statin, atorvastatin 40 to 80 milligram, rosuvastatin 20 to 40 milligram, and don't forget lifestyle modification. Reassess the lipid profile after 1 to 3 months. The target is 50% reduction from the baseline and to reach an absolute value of LDL cholesterol below 70. After achieving the primary target, we should look for the secondary target. Non-HDL target is less than 100, and always screen and manage the other cardiovascular risk factors: diabetes, hypertension, obesity, and smoking for total cardiovascular risk reduction. And thank you so much.
Thank you so much, Dr. Ahmed Mohsen, for this amazing overview of the update of the 2025 version for the 2019 version of the dyslipidemia guidelines. We have some questions on the chat box from our dear colleagues and viewers. So Dr. Ammar Safadi is asking you, if you have 2 risk modifiers are present, should the patient risk be upgraded twice? For example, obesity and stress?
No, it will be upgraded once from moderate to high risk only.
Okay. The second question from Dr. Rumaitha Sabri. She has a male patient, 43 years old, pre-diabetic, not on medications. He has total cholesterol of 310, LDL of 200, and obese. Is he indicated for a dyslipidemic medication, and what would be the plan of such a medication?
For sure. Actually, this was the last slide in the presentation. Accidentally discovered markedly elevated LDL cholesterol level 190 milligram or more is considered a high risk patient by default. There is no need to calculate any risk score, and the target LDL will be less than 70 milligram. Then try to achieve the non-HDL target below 100. Ask for don't forget to rule out a secondary cause first. At least we have to obtain a thyroid profile and ask about drug history. If it was a primary lipid disorder, then we will start with atorvastatin 40 milligram, for example, or rosuvastatin 20 milligram. After obtaining the standard baseline labs, which include liver enzymes and the total CK. Before we start statin, we should have a normal baseline of ALT, AST, and total CK. If normal and no secondary cause, give high intensity statin, repeat the lipid profile after 3 months to check whether the LDL target is achieved or not. And don't forget to screen the first degree relatives.
Thank you so much, Dr. Ahmed. Dr. Fatma Sharif is asking you a question. She has a mother, and this mother is breastfeeding. She is hypertensive, and her LDL is more than 140. So, what is the medication plan that would be considered safe to a breastfeeding mother with such a condition?
Okay, actually, this is a very, very challenging scenario. Statins are contraindicated in lactation. If I were you, this scenario actually is not stated clearly in the guidelines, so I will give you my own opinion. If this LDL cholesterol level accidentally discovered in an as asymptomatic patient, and this is considered a primary prevention, no problem. Wait until she finish her lactation, then start statins. We can't give statin during lactation. The other option is to stop lactation and to start statins, but I don't prefer this option. There is no urgency. We are talking about primary prevention. So with this LDL of 140 not markedly elevated, I will wait after she finish the lactation, then I will start statin after that.
Thank you so much, Dr. Ahmed. Dr. Ammar Safadi is asking you, if the non-HDL is high but the LDL reached the goal, would you follow the same steps of treatment or would you have a different plan?
High HDL?
Non-HDL, يعني
Oh,
VLDL, and as you know, the other components,
okay.
HDL, but not LDL. The LDL itself is within the goal.
Okay. This was clear in the original guidelines. We have four categories in which we shouldn't look for the LDL alone. The first category is like this patients with low LDL cholesterol. Number two, patients with diabetes. Number three, obese patients. Number four, patients with high triglyceride levels. In these four patients, I call them told as a mnemonic. Triglycerides high, obesity, low LDL, diabetes. Don't be deceived by the low LDL and look for the non-HDL cholesterol level. In this scenario, mostly the triglycerides is very high, and the LDL, which is shown in the lab result, is not correct, as it is calculated from the Fredwold formula, and it will not be accurate if the triglycerides more than 400. This scenario is very, very famous in diabetic patients who are diagnosed for the first time, markedly uncontrolled diabetes. Usually the first lipid profile you will find the LDL is low 70 or 60, but you will find the triglycerides is very high, 400, 500. So after you strictly control the diabetes and with a subsequent triglyceride reduction, the actual LDL level will appear. So if you to summarize, if the LDL is within the target, no problem. Look for the secondary target, which is the non-HDL cholesterol level.
Dr. Muhammad Sami is asking you a question about inclisiran. Does it have the same documented cardiovascular benefit as the other monoclonal antibodies, or
No,
the published data is more towards one side?
no. Till now, inclisiran hasn't given a recommendation in the focused update, as they are waiting for ongoing trial, which expected to finish in 2026 and or 2027. So it is till now it is considered an alternative for the well-established PCSK9 monoclonal antibodies.
Thank you, Dr. Ahmed. Dr. Ahmed Dardir is asking you a question about a 30 years old young lady. Her LDL is 220 and repeated in another lab also to be more than 200. She has a desire to get pregnant. She has no family history of premature coronary artery disease. Should she take something during pregnancy, or should we postpone her plan of management until after delivery And if so, what would be this plan of management?
LDL 200.
Yes, and she's 30 years old and she has no family history of premature coronary artery disease and she's planning to get pregnant.
Okay. Actually, this scenario is also out of the scope of the guidelines, and no clear answer in the literature. The new guidelines for management of heart disease with pregnancy gave a class 2B recommendation for statins during pregnancy for patients with familial hypercholesterolemia. To be honest, I will wait along. I will wait a lot before implementing this recommendation in my practice. We have a fixed knowledge for many years that statins are contraindicated in pregnancy, and even the ESC guidelines for management of chronic coronary syndrome 2024 stated clearly that statins are contraindicated during pregnancy and lactation. Then after 1 year we have a new guidelines states that it is a class 2B recommendation during pregnancy. But if you want my own opinion, I will explain the risk for the family. If she is insisting on getting pregnant, I will also wait until she finish her pregnancy, then start the lipid lowering therapy. Other options include the use of um, locally acting agents that inhibit the cholesterol absorption from the GIT. Bile acid sequestrant can be used during pregnancy, but to be honest, I don't have a personal experience in using such medications during pregnancy or even in non-pregnant ladies. So bile acid sequestrant is considered safe during pregnancy. LDL apheresis is considered option as well, but the implementation of this recommendation in the real life, I think, will be very, very challenging.
Yeah, I agree with you that it would be the wisest option to leave this patient to finish her pregnancy. And after she delivers her baby, we can start to treat her just like any other patient. So,
Yes.
doctor, we have another question. Uh, regarding the score 2 system, is it used only to guide the statin therapy or it has other uses in the medical practice in these guidelines?
It is designed mainly for this purpose to guide the lipid lowering therapy. Actually, it was removed from the hypertension guidelines apart from patients with elevated blood pressure. Patients with elevated blood pressure, the use of score 2 and score 2 OB is recommended for risk stratification. For example, if we have a patient with elevated blood pressure and blood pressure values is 130 over 80 millimeter mercury or more, after 3 months of lifestyle modification, and still this blood pressure value is persistent, 130 over 80 millimeter mercury or more, after 3 months from lifestyle modification, and score 2 or score 2 OB 10% or more, or score 2 or score 2 OB from 5 to less than 10% plus risk modifiers. We have another risk modifiers written in the hypertension guidelines. In such case, it is recommended to give antihypertensive medication together with lifestyle modification. And this is also considered one of the indication to start with a monotherapy, to use a single antihypertensive agent, not the dual combination as in the classic patients with hypertension.
The last question from Dr. Ahmed El Warawi is asking about the patients with acute coronary syndromes And what is the desired target LDL? I mean, he's asking when are we not expected, when do we say that this patient did not reach the LDL? What is the target LDL? I believe it's less than 50% from the LDL that got the ACS. What do you think?
Yes, yes, for sure. 50% reduction from the baseline, and to reach an absolute value below 55 milligram. And don't forget the extreme risk category. If we
Yes.
have a patient with recurrent events despite taking a maximally tolerated statin dose, or patient with polyvascular disease, peripheral arterial disease, and coronary artery disease, or cerebrovascular disease. This is also considered an extreme risk patient, and we should target LDL below 40.
For Dr. Ahmed Al-Barawi, if this patient has an LDL of 30, and he got an acute coronary syndrome on the LDL of 30, the target LDL will be less than 15. Simply speaking, yeah. It is, we always get the lowest one. If the 50% is the lowest, okay. If the lowest is less than 55 or 40, as Dr. Ahmed Mohsen said. An amazing session, an amazing collaboration from the attendees and questions. We got more than 22 questions. We have more than 125 attendees live, apart from the 12,000 subscribers to the cardiology education channel now. And this meeting, as recorded, will be published there as well. I would like to thank Dr. Ahmed Mohsen so much for sharing his knowledge and expertise and everything with us tonight. Ahmed did an amazing job. Thank you so much, Professor Ahmed. And I can never be thankful enough to your contribution to all our colleagues and co-workers everywhere. I will not take a very long time because already we took the creme de la creme with Dr. Ahmed Mohsen. I will show you something interesting about the updates from the clinical trials, which is called the late breaking trials in the ESC 2025 in Madrid. We have a very interesting trial about the revascularization for STEMI patients. What are the options for those patients? And looks like this debate is continuously going on, maybe for the past 10 years or more. Dr. Ahmed, is my slides in full screen and moving?
Yes.
Okay, so that's very good. So this is an OPTION-STEMI. The name of the trial is OPTION-STEMI, and it was a trial from Southern Korea, okay? South Korea presented several of the late-breaking trials. You will be shocked to know that 30%, one-third of the late-breaking trials in the ESC in Madrid were presented from South Korea. And this is a very, very strong ongoing healthcare and scientific research system out there. The trial design was a non-inferiority design. It was comparing two strategies of revascularization. The first strategy is the immediate complete revascularization. The second strategy is the staged complete revascularization before hospital discharge. So this is what is new about this system, or what is new about this strategy, or what is new about this OPTION-STEMI. Both arms of the patients were revascularized before hospital discharge. The first arm was revascularized immediately, and the second arm was revascularized in the next subsequent days before hospital discharge. And it was not designed to be a superiority trial. It was designed to be a non-inferiority trial with the initial hypothesis that the staged revascularization is better. Meaning that we are starting the trial and we are expecting that the complete revascularization is better from all the previous data in the staged form. But the question is comparing it to immediate complete revascularization, and is it non-inferior or no? I want this question to be clear to everyone because this is the core of such a trial. What is the evidence that we have now before this trial was published? Before the end of August 2025, we know since 2019 from the 6 or 5 major trials, the PRAMI, the Culprit, the Dynami 3, the Primulti, the Compare Acute, and the Complete trials. So we know from those trials that any patients presented with a STEMI, thrombotic total occlusion of an infarct-related artery, will be completely revascularized. This question has been answered. We're not going to leave a patient with a critical stenosis after we fix the LAD. We're going to leave a critical stenosis in the RCA, or after we fix an inferior STEMI, we're going to leave a critical stenosis in the LAD. We answered this question since 2019. But the other question where the answer is unclear is when. When should we fulfill the other arteries? Okay. And in this context, the current ESC guidelines says that the complete revascularization should be done between the hospitalization and between 45 days. This is class 1A. So between the patient is hospitalized and between 45 days, you will need to fix all his coronary arteries. Okay. Before discharge from the hospital, it is class 2B to perform immediate complete revascularization in hemodynamically stable patients with STEMI without complex coronary artery disease. This is the current status of the guidelines. We have 2 other major trials in the past 2 years that discussed the same concept like the OPTION-STEMI trial. They are not exactly the same, but they are somehow similar. One of them is called the BioVasc, and the other one is called the Multistars MI. The BioVasc included patients with acute coronary syndrome, full stop. You included non-STEMI and STEMI patients. And the Multistars involved patients with KLIP class 1 and 2 only. So you have patients with low-risk STEMI patients. The BioVasc and the Multistars were non-inferiority trials, and the results were positive regarding non-inferiority. So it opened the door for the OPTION-STEMI trialists to design the OPTION-STEMI trial to include all the patients with STEMI, including KLIP class 1, 2, and 3, excluding the patients of cardiogenic shock. So it didn't include KLIP class 4. So KLIP class 1, 2, and 3, but only with STEMI. Non-STEMI was not included, and nearly up to 1,000 patients were included. So this is the design of our trial. 994 patients with STEMI and multi-vessel disease. Multi-vessel disease defined as what? Defined as 2.5 millimeter diameter vessel, coronary artery, showing 50% diameter stenosis by visual evaluation other than the infarct-related artery. All of those patients underwent primary PCI. After they fixed the culprit artery, they were randomized in a 1-to-1 fashion. Half of those patients in the arm of immediate complete revascularization underwent an ad hoc procedure to complete the revascularization. The other 50% were revascularized before the hospital discharge, between days 2 and 4. Between days 2 and 4. And the primary endpoint of the trial comparing the 2 arms was a 12-month follow-up, the composite of all-cause death, non-fatal MI, and unplanned revascularization. So hopefully this is clear enough. I put some effort to explain how this trial was designed. This is a comparison between the OPTION-STEMI, the BioVasc, and the multi-stars. OPTION-STEMI included STEMI patients, BioVasc included STEMI and non-STEMI. Only 600 patients of the 1,500 were STEMI. And multi-stars included STEMI patient. The treatment strategy was immediate complete revascularization versus the stage. OPTION-STEMI included in-hospital stage. BioVasc includes stage within 6 weeks, 42 days. Multi-stars include stage up to 45 days. Hypothesis of the 3 trials were non-inferiority. The primary endpoints were similar. So let's see the inclusion and exclusion criteria and procedural details in the OPTION-STEMI. Patients were eligible to enter the trial if they presented with a STEMI and a multivessel. And I will explain the multivessel to be non-culprit artery with 2.5 millimeter diameter or more and 50% stenosis or more by visual evaluation. Number 2, he underwent a successful PCI for the culprit artery, achieving a TEMI 2 or 3 flow with residual stenosis less than 20% in the infarct-related artery. The patient who was late presenter more than 12 hours before the primary PCI was excluded from the trial. And the patient with cardiogenic shock, unprotected left main, and CTO were excluded also from the trial. Regarding the procedural details, let's see that we have a patient with a 60% stenosis or between 50 and 70% stenosis in the non-infarct related artery. This patient will undergo FFR. So the moderate lesions will be evaluated by FFR. If they are significant, they will be revascularized. If they are not significant, they will not be revascularized. This is explainable. Number 2, if the patient has more than 70% stenosis by visual evaluation, then this patient will be revascularized. Number 3, the type of the stent used was the Synergy stent, which is one of the best stent in the world, but it was not exclusive. The doctor, the operator was allowed to use any other stent, was allowed to use drug-coated balloon, was allowed to use plain balloon according to his discretion of the procedure. I want to show you that this was like a real life trial. Even the use of glycoprotein 2B3A, the use of thrombus aspiration, everything was allowed according to the operator discretion. And the follow-up was done up to 12 months as we showed. From these 2 big tables, I want to focus on 2 things. On the left-hand table, the primary endpoint, which is death from any cause or non-fatal MI or any unplanned revascularization, was 65 patients in the immediate complete revascularization versus 53 patients in the staged revascularization. So more patients died in the immediate complete revascularization versus the staged. And as you can see in the right-hand table, complications during hospitalization, cardiogenic shock, 18 patients in the immediate versus 9 in the staged. Cardiogenic shock, يعني deterioration for patients with 2 or 3 Killip class to be 4, 15 in the immediate group versus 8 in the staged group. The need for mechanical circulatory support, 10 in the immediate group versus 5 in the staged group. What is the message that you're getting from such a trial? You're getting from such a trial the message that usually if you decide to do an immediate complete revascularization, your patient will not get a benefit. So let's see the spectrum of our patients. Did all the patients lose the benefit? Or is there any subset of the patients that can catch the benefit? I want you to look here. As you can see, all the boxes are on the right-hand side favoring staged revascularization. Only 2 boxes are on the left side favoring the immediate revascularization. Those 2 boxes are what? Young age below 65, KLIP class 1. So this is the message from the trial. You have a stable patient that is young age with KLIP class 1. This is the patient where you can do the immediate revascularization on the table. Otherwise, it would be much more wiser and beneficial to postpone the other vessels than the ad hoc procedure, but to be performed before discharge. This is the discussion. We know that you will fix all the vessels since 2019, as we said, from the PRAMI, culprit, dynamic, primulti, compare, acute, and complete trial. The timing was the question. This was studied previously in the BioVasc and the multi-stars, and now they designed the OPTION-STEMI. The added value of the OPTION-STEMI, it was a large scale, nearly 1,000 patients, randomized. It showed the real life practice, choosing FFR in the moderate lesions, not choosing FFR for the tight lesions. Some patients will need thrombus aspiration. Some patients will need 2B3A inhibitor. This is a real life trial. And it included patients with KLIP 1, KLIP 2, and KLIP 3. So you have all the spectrum of the presented patients. But what was the result of such a trial? The result was that there were more adverse events if you decide to do the complete revascularization ad hoc at the index procedure. And these were included in all the groups of the patient except 2 groups. The young patients with KLIP class 1. So as I highlight here, those findings indicate that the immediate complete revascularization can be considered for which subset of patient? Hemodynamically stable patients with low risk and below the age of 65. Otherwise, the trial failed to show non-inferiority. We're not even speaking about superiority. And this is led to the conclusion that the immediate complete revascularization might be harmful in some patients, especially those with KLIP class 3 and signs of heart failure. And those patients were excluded from the other trials, but now they were included in the OPTION-STEMI. I will not make a prolonged presentation. Thank you so much for everything and for attending with us. And I will check the box if there is any questions available here. So Dr. Ahmed Zaini is asking, if the patient is ACS STEMI after doing the culprit, but I have bifurcation lesion, what to do in this case, despite the trial encourage complete revascularization? So again, Dr. Ahmed, the guidelines does not encourage complete revascularization only. It's class 1 to do complete revascularization. The question is when, Dr. Ahmed? When will you do it? Will you do it on the patient on table, or is it wise to wait for 2 to 4 days before hospital discharge? This trial was clear enough to give you the message, Dr. Ahmed. The message is, do the primary PCI for the culprit artery on the table and stop working unless your patient is young and KLIP class 1. Otherwise, the patient will be postponed until when? Until before hospital discharge, according to OPTION-STEMI, or until 45 days, according to the available version of the guidelines. And in this case, Dr. Ahmed, You will perform the bifurcation lesion. You can perform any other kind of lesion, but please, on the ad hoc procedure, just do the culprit artery. I hope this is clear, Dr. Ahmed. Thank you so much. Dr. Ahmed Mohsen, do you have any comments?
Excellent presentation as always, my dear friend and professor, Dr. Muhammad. I really enjoyed the presentation and thank you so much.
I would like to thank, of course, Dr. Ahmed Mohsen for allowing us to join him today and learn a lot from him. Dr. Arafa is asking, in a case of low risk with complex PCI on non-culprit. Okay, Dr. Arafa, the patient, we're not looking at the coronaries, we're looking at the patient. The patient is CALIP class 1. The patient is below 65 years of age. You can proceed. The patient is CALIP class 2 or 3, meaning your patient has congestion, fine basal